Disability. Now disability is something you should have been assessing all along. But during this time, we're really going in for the final assessment. With infants and pediatrics, it's very important if they come in unresponsive, not acting well, that we go and assess their wakefulness. That is AVPU. Awake, awake to verbal, awake to pain, unresponsive. They're not unresponsive until we go in and assess that they're unresponsive. So I come in, the baby's sleeping. Hey, little Johnny, 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 wake up for me. Now Johnny's unresponsive. Now I feel for that pulse, hey, I need help in here. Bring the crash cart. We don't like when kids are unresponsive. We come in, Johnny's got his eyes open, he's looking good, he's cooing, he's smiling, he's acting appropriately. Neuro check, good. The other piece of this is not just AVPU, but PEARS checks. So if they're unresponsive, we need to check their eyes. We don't know if little Johnny possibly got into any poisons. That could affect his eyes. So if we see them constricted, dilated, shaken baby syndrome. If somebody shakes a baby too hard, that can cause brain death. And so you may have eyes that are fixed and dilated. The eyes tell us a lot. So if somebody's unresponsive, PEARS is imperative. The last thing we need to check, and this is standard for every pediatric and infant patient that comes in unresponsive or just not acting right, we do a blood glucose check. It is part of disability. And I have to tell you, my first code, when I went to an adult hospital to do the emergency department, I ran in with the blood glucose because I came straight from pediatrics. I got the glucometer, I'm ready. And they looked at me like, really? So it's all good. I'm telling you, with pediatrics, think glucose. Kids will code with a low glucose, and we'll talk about that in the video. For infants, normal glucose is above 40, little infants, neonates. Most of the time we want it at 60 or above. So if they're even below 60 and they're not acting well, they're neurologically compromised, you're probably going to need to check with glucose. When we talked about D50%, but within infants, when we give medications, we usually dilute everything down. Infants don't metabolize like adults, so medications are all weight-based. And we're going to be practicing that in simulation. We're going to need to figure out how much to give an infant compared to a pediatric compared to an adolescent. So far, we talked about D50% dextrose, and we gave the whole amp to an adult. That's not the case for pediatrics. And if you have a little peripheral IV, that D50 is going to be too much for that little vein to take. So usually we dilute it down to a D10% solution. The last thing with disability, glucose, note, that's AVPU. We can do a Glasgow Coma scale. The older they get, the more we wanted to possibly incorporate a Glasgow Coma scale. Let's talk about this real quick again, reinforcing Glasgow Coma scale indicates how stable they are, and this also impacts how well they're protecting their airway. So Glasgow Coma scale that is going below an 11, they're more likely to be unable to protect their airway. And so when we talk about our adults and our adolescents and even our older pediatric patients, the Glasgow Coma scale can be a very, very beneficial tool to use in our assessment. That was disability. I look forward to seeing you in class. Thank you.